My name is Nita Lee. I'm a GYN oncologist at the University of Chicago Comprehensive Cancer Center, and I'm really pleased to share with you some information about gynecological cancer 101. Many of you may be cancer survivors or caregivers, and I think of this as more broad overview of what to know and what to share to others, because I think as survivors and caregivers, you're often put in a position where people are asking you questions as well, and I hope this can be a resource for people in the future. My overall objectives is to provide some basic statistics and understanding about patients experiencing GYN cancer in the United States, including a bit about an understanding of disparities. I want to provide an overview of risk factors, symptoms, prevention opportunities, and early detection for GYN cancers, and provide a broad overview for treatment for the initial diagnosis and treatment options for patients diagnosed with cancers. I know throughout this conference, you're going to have a lot more detailed opportunities to listen in on more very specific treatment choices for ovarian cancer and other entities, but I'm hoping that this can provide some background. So some of the common themes that I think about is that as a whole, GYN cancers and those patients who are diagnosed with cancers, it's still considered a rare tumor in the larger scope of things when you look at the individual 5 cancers. I think when we think about GYN cancers as a whole, there's a lot more women and people who are diagnosed with these cancers, and it's important to kind of think about how some of these things are in common. Unfortunately, there's less awareness in the public and by providers. And in general, we think that below the belt cancers still have more stigma associated with them. And this often prevents an open discussion, and it can often present in delays in diagnosis or in sort of seeking care because some of the symptoms are harder to talk about or to explain. So we really want to demystify some of those things and make these things that we talk about and that we share with our friends and family. I think, unfortunately, women's cancers and symptoms are often dismissed. And because of that, there's often even less designated money for education, care navigation, and research. So we're really hoping to change that. And we really hope that you can take your experience to help us do that in your own settings. So one important thing is the role of a GYN oncologist specialist. So this is a specialist who's trained, like myself, in obstetrics and gynecology and has done additional 3 to 4 years of training in GYN oncology in the spectrum of advanced surgery, chemotherapy, and therapeutics. We know that we have evidence that surgical management by GYN oncologists improves the rates of optimal surgery and overall survival. We know that experience and high volume matters, and we know that the surgical team, the surgical support team, and the hospital matters. We also know that this may affect chemotherapy and access to clinical trials that are specific to GYN cancer and are the most up-to-date available options. So when we look at 2024 and we think about statistics and cases, we see that in 2024, new cases, the most common GYN cancer will be uterine cancer, which is about 67 to 68,000 new cases a year. Ovarian cancer, vulvar cancer, and vaginal cancer are a little less common, as you can see here, with ovarian cancer probably having about 19,000 cases per year. And we see that deaths due to these cancers still are very important to think about. When we think about uterine cancer and ovarian cancer, those are the cancers that are most commonly associated with who is having deaths due to this cancer. And we see that over the last several years, the number of deaths due to uterine cancer has actually surpassed ovarian cancer. And we'll talk a little bit about those reasonings. The important thing to think about is that there are many cancers that can affect women, but we can see as a whole, when we think about all GYN cancers, that's really a very common thing that we need to be thinking about and move it away from this idea that it is so rare. So I'm going to first talk a little bit about ovarian cancer. As we talked about, there are new cases that happen every year and the estimated deaths. Now, 5-year survival can be a very difficult thing to think about. It doesn't mean that we stop caring at 5 years or that everyone is going to be in that category. So I never think of any individual person as a number or a statistic, and I don't want to think of that being like an overview of what may be happening to yourself or to your loved one, but I think it's important to think about. We also know that sometimes it's just a question of like we have many people who are surviving longer than that, but the statistics are captured at a very just early level. We have some really improvements in ovarian cancer survival that we're seeing over the last 20, 30, 40 years. And that's really encouraging as we're thinking about new therapeutics and new diagnostics that are coming out. The incidence of ovarian cancer varies by age, and we can see that in general, the incidence peaks in kind of the late 60s to 70s, though patients who have a genetic predisposition, that might actually happen earlier. So it's really important to kind of think about like different issues. If you have an overall lifetime risk for any general patient who has ovarian cancer or any women who have ovaries, it would be about 1.8%, but this can increase in patients who have genetic predisposition. So there's multiple different types of ovarian cancer, and there's a diversity of this that's really important to think about because not all ovarian cancer is the same. We also know that ovarian cancer becomes the bucket that we talk about fallopian tube cancer and primary peritoneal cancers, which are all in that category of epithelial ovarian cancers. So when we think about different portions of the ovary as to where cancers can come from, this has actually gotten more complex as we've learned more, and I'll share in a bit. Some come from the surface epithelium, some come from the fallopian tube, and others come from cells that are more central into the ovary that are supportive cells as well as germ cells, which would otherwise turn into an egg that you ovulate with. We know that ovarian cancer can often spread to local structures, and this is an example of local structures where you see the uterus, the ovaries here in white, the fallopian tubes, and the bowel. So you can often see in the bladder here, so you can kind of see why symptoms are sort of related to the other structures that are in the pelvis. So oftentimes we think about this, and again, it's not one disease. For example, many epithelial ovarian cancers may actually be arising from the fallopian tube, where the normal fallopian tube can undergo changes and become precancerous and then turn into invasive cancer and attach to the ovary or to the primary peritoneal surfaces. So this has really changed the way that we think about the diversity of how we approach treatment, as well as how scientists are really looking at kind of the diagnosis and screening potential, because as you know or may know, that there's not a screening test for ovarian cancer. So again, this really goes to like the diversity of these different cell types. And although this is kind of a very academic box of kind of where we put, different types of tumors, it's sometimes really important to be able to ask your doctor, what is my type of ovarian cancer? Is it an epithelial ovarian cancer? Is it a non-epithelial ovarian cancer? And that is one of the biggest distinctions that we have. And sometimes we have a big distinction between low-grade cancer and high-grade cancer. And this is because these different cell types can have different clinical presentations, age, symptoms. There's sometimes different optimal treatment regimens. They have different recurrence risks. They have different responses, and the treatment options may vary depending on if it's a new diagnosis, a recurrence, or anything like that. There's also different biological and molecular mutations that happen at the cell level or within the cell, and different pathways that can be turned on and off. And as you may see a little bit later in my talk, as well as with some of the other discussions, sometimes, especially in the recurrent setting, a lot of these different pathways and molecular targets are what we want to target to better personalize people's options for treatment. So ovarian cancer often spreads very early in the disease site from the ovary to other areas. So it can land on secondary sites and establish growth in the abdominal cavity. And we know that a lot of times this is a really important and unfortunate situation because these cells can spread before there's a lot of symptoms. And so a lot of the work that gets done in different laboratories is to really understand, can these steps be better studied? Can they be stopped so that we don't have the majority of our patients with ovarian cancer presenting in stage 3 or stage 4, which is the typical thing that we still see. Again, it can spread into direct extension into the abdominal cavity. So from down here in the ovary, which is here, to all the way through via the lymph node system, which is the lymphatic system, to the surfaces of the peritoneum, which is very common, where you can have these different cells that shed and land on the surface, do not necessarily invade deeper, but can really cause a lot of trouble and can cause a lot of bowel symptoms. The understanding of the spread can explain why certain people have certain symptoms. Again, less commonly through the bloodstream. And again, unfortunately, most women are diagnosed with stage 3 or 4, meaning that it is spread into the peritoneal cavity or beyond. So ovarian cancer is usually not a silent disease, but that can be tricky because people don't often get symptoms until that spread has happened. But very common symptoms can be bloating, difficulty eating, abdominal pain, changes in urinary frequency or sensation of pressure. Other symptoms can be fatigue that are a little less common, indigestion, back pain, pain with intercourse, constipation, or menstrual irregularities. Now, the hard part about a lot of these symptoms is that they can be common for many women during their cycle. They can also be shared between different things, such as endometriosis or fibroids, or different common symptoms related to menopause. So it's important to think about symptoms that are new and different for you and being able to report those to your doctor, have a gynecological exam so these can get a workup, which may include an ultrasound or even a CAT scan if they're more serious. So again, symptoms that are new, different, persistent, especially over like a new 2 to 3 week, even 1 month time period, should raise an alarm to say, hey, I should get this checked out. Now, it may not be ovarian cancer, but it's important to kind of think about what you can do to get this investigated and to be persistent. If someone doesn't listen and blows this off, it's important to kind of think about seeking other care or maybe even seeking a different provider. And I always want people to feel very empowered to do that. So oftentimes we'll start with a full physical exam and imaging studies, which are pictures, an ultrasound, a CAT scan, a PET CT. We often start with blood work, tumor markers. People have often heard of the terminology of CA-125. It is not a screening test. So if somebody doesn't have a mass or symptoms like that, we don't get it. But if there's a mass, we sometimes will get a CA-125. It's also used to follow people who have a diagnosis of ovarian cancer. Unfortunately, there's not a test to screen women who are asymptomatic for ovarian cancer. Now, high-risk women who have family history may have other options that we can talk about, but none of those things are perfect. But this is if you have a high suspicion what we will get done. So the initial treatment tends to include a combination of surgery or chemotherapy, and sometimes there's decisions on upfront or primary surgery or a biopsy to get a diagnosis, and starting with chemotherapy, which is often called neoadjuvant chemotherapy. To back up a little bit, here are some risk factors. So what are the risk factors for ovarian cancer? This can include age, family history, including breast and ovarian cancer, infertility, personal cancer risk, early onset of your period and late onset of menopause, endometriosis. Things that we know decrease the risk of ovarian cancer include the use of oral contraceptive pills, pregnancy, tubal ligation, even if the ovaries aren't removed, breastfeeding, risk-reducing surgery for high-risk genetic mutation carriers, such as the removal of the tubes and ovaries after completion of childbearing, has shown to improve survival and decrease breast cancer. Salpingectomy, which is the removal of the tubes instead of getting your tubes tied, is something that we now offer to women who are having indications for having a hysterectomy or their tubes tied, and that has shown to decrease ovarian cancer in the general population as well. So jumping again, in terms of cytoreductive surgery or the tumor debulking surgery, when we are doing this for the surgical treatment of ovarian cancer, our goal is to have no visible disease left. If we can't get to optimal in the no visible disease, we still think it's optimal if we have no large tumors left. Usually, this is open surgery with removal of uterus, tubes, and ovaries and any visible tumor. I will say, and I didn't add this to the slide, there is a role for robotic or minimally invasive surgery for patients who've had chemotherapy first and have had an excellent response. And there are some ongoing clinical trials looking at this. There's also improved outcomes that we know related to high volume centers and treatments with specialists. We also know that there is a role for intraperitoneal therapy, which is called HIPEC, heated intraperitoneal therapy with chemotherapy, which is during the interval surgery, or potential intraperitoneal chemotherapy delivered after surgery. And those are some specialty things that you can talk to your GYN oncologist about to think about how does the surgery relate to chemotherapy. So initial chemotherapy is generally a two-drug combination. The more common drugs that we often use and are often the backbone are carboplatin and Taxol, generally 6 cycles given once every 3 weeks over a period of about 4 months. If you receive neoadjuvant chemotherapy, the chemotherapy may be split before and after surgery. Clinical trials often add to the backbone of this. So you may be offered a clinical trial that includes carboplatin, Taxol, and some additional drugs. Maintenance therapy after initial chemotherapy also needs to be specialized, and that includes a class of drugs called PARP inhibitors or bevacizumab. And this again really depends on the specifics of your tumor type, as well as the specifics of where your cancer is located and some of these molecular diagnostics that are now done to really learn more about these cancer cells at a molecular level about, again, like we were talking about, what things are on and off that could be used. So maintenance therapy, there is good data on the maintenance of the additional biological or chemotherapy agents. The PARP inhibitors are a really strong foundation for this, and this actually really often includes why it is important to think about genetic testing, because we know the group that benefits the most are patients who may have a genetic mutation that allows them to benefit from this, or a group that may have tumor genetics, which we will get into a little bit of, called HRD, human homologous recombination deficiency, that may make PARP inhibitors more attractive. We can think about these things, and I'm not going to get into a lot of this as this is a 101 talk, but we really want to think about these terms and thinking about who should get these additional medications, for how long, the cost, the side effect profiles, and really think about personalization based on molecular profiles. So if you're somebody who's newly diagnosed, you may want to think about like asking your doctor, do any of these things apply to me and how? So I often think about for ovarian cancer, there's a lot of peaks and valleys to think about. And so this talk does not cover a lot of discussion about recurrence and treatment for recurrence, but I want to think about sort of these post-treatment, initial treatment peaks and valleys. So the peaks are that you're completed therapy, you've accomplished a lot in getting through that. Many of the chemotherapy side effects may be resolving. There's some freedom from appointments and an ability to return to a more normal schedule. But there's valleys. There's worry about cancer recurrence and surveillance. There's a sudden change in the diminished provider and cancer team support. We need ways of thinking about reassurance and finding the new normal. So this element of survivorship and care is something that is really important to talk to your care team about and think about how you're processing. So the goals after initial treatments, and this actually applies to all GYN cancers, but I'm putting it here since we're talking about kind of like different steps of the cancer journey, is surveillance for cancer progression, recurrence, or secondary cancers, assessment of medical or psychological late effects. And it's really important to some compared to other early cancers, which may have a little bit of a less recurrence risk because we know ovarian cancer does have a higher recurrence risk. We also want to think about prevention of new cancers and of late effects and interventions related to issues of pain, fatigue, psychosocial distress, sexual function, and other conditions that may be related to employment, insurance, getting back to work. All of those things may be an important way that we need to think about our care team and how you can approach these. So I'm going to shift gears and talk about uterine cancer 101. This is the most common gynecological cancer that's diagnosed in the United States. As a fast fact, the symptom is often irregular bleeding or vaginal discharge. And to level set, the endometrium is the inner lining of the uterus. And so while some uterine cancers can occur in the muscle wall or in the stromal supportive cells, most uterine cancers are known as endometrial cancers and occur in the lining that sheds and grows as well. So I'm going to spend a lot of time talking about endometrial cancer and uterine cancer in general, and I'll break that out when we're talking about sarcomas or mention that as well. So all uterine cancers are actually growing, and the rate of uterine cancers is actually unfortunately increasing, and that's why it's surpassed many other cancers. So close to 70,000 women will get diagnosed, and every year we're seeing increases. The survival overall is actually good for patients who are diagnosed with early low-grade cancers. The problem is the incidence of higher stage cancers and higher risk cancers is increasing, and the 5-year survival for those cancers is more similar to ovarian cancer. The lifetime risk of developing ovarian cancer is 3.1%. And the prevalence is that there in 2021, close to 900,000 women living with uterine cancer in the United States. We see that there's, in general, the rates of new cancers are fairly similar. However, we see that Black women are slightly more likely than white women and other groups to develop this cancer now in the most recent data. The age of onset is about median age is usually between 55 and 64. And you can see this is where the majority of patients get diagnosed. But we're actually seeing very significant trends in newer cancers and the trend in cancer diagnosis happening more frequently in women in their 30s and 40s. And that's really important to think about for prevention and early detection. The really unfortunate part is that uterine cancer is one of the cancers with the biggest disparity by race and ethnicity. And we see that non-Hispanic Black women have the highest mortality rate or death rate per 100,000 when you see this or compared to other races and ethnicities. And this has to do with the cell type of the type of high-risk cancers that Black women may be more likely to get, as well as other factors that may lead to decreasing early diagnosis, which includes bias in symptom recognition, bias in being able to be referred to get workup for symptoms, and treatment. So there's a lot of biological differences, not between people, but in terms of cell types that we're sometimes seeing, and those cell types may drive outcomes. So am I at risk? Now we know not all women who have these risk factors or people with a uterus who have these risk factors will get this. Women after menopause or increasing age, weight, diabetes, hypertension, family history, tamoxifen use, irregularity of periods. All of these elements can really be factors that we know about, but it's not a perfect answer or perfect story. So the big thing to know is that uterine cancer symptoms, vaginal bleeding, what is normal and what it needs workup. Vaginal bleeding after cessation of periods. So if you've not had a period for 1 year, that's considered menopause. And it's not normal to start bleeding again. So it's not just your period coming back. It's not just the end of your menopause. It really requires workup. Unusual discharge. Irregular patterns of bleeding, even before menopause, need workup, especially if you may have other risk factors. So listening to your body and recognizing the importance of sharing this with your primary care doctor, asking for a gynecology referral, and not being afraid of saying, hey, this spotting happened once, but I know it's not normal, so I'm going to seek care, as opposed to waiting to see if it happens again. So unfortunately, many women who see me with a diagnosis of uterine cancer say, well, it only happened once, and someone told me that it was just my fibroids, and then they don't get a workup, and then we're dealing with a more serious situation. I think this just kind of goes over some of the same things that we talked about, symptoms and risks, and can serve as just a little bit of a guide, so I won't spend too much time on that. So how is uterine cancer diagnosed? It is often diagnosed by an endometrial biopsy that can be done in the office or in the operating room with a what's called a DNC, which is an outpatient procedure that can be done with sedation. In the office, it's a very tiny, very, very narrow, flexible tubing that's only a couple millimeters in terms of size. So that's why it can be done in the office. Transvaginal ultrasound is actually something that we do to assess the lining of the uterus. So it should be nice and thin like this and not bulkier. But we know that there can be problems with ultrasound only, and the biopsy is really the standard, biopsy or DNC. Hysteroscopy is doing a DNC, but actually looking with the camera inside the uterine cavity to better target and get enough tissue. So there's a lot of different things that can be done in workup and that can be important. So when we get a biopsy result, we know that there's a lot of diversity, just like there was in ovarian cancer, of what the cells can look like. And I don't mean to put this up to kind of like, explain this, but I often talk about the cell type can give us an idea about how the cancer might behave and may help us guide surgery and treatment afterwards. The grade of the tumor refers to what does that tumor look like under the microscope? What do the cells look like? How crowded are they? How much do they look like the original uterine cancer? From a scientific and molecular pathway, we actually think about molecular testing, and we get a lot of information about the tumors that may not be as relevant when we're talking about the initial steps, but we learn about the proteins and the molecular profile of like what proteins are on and off, what hormones are on and off, or receptors are on and off. That can help guide treatment. So endometrioid is the most common type, and grade 1 and grade 2, which are considered the low grade types, tend to be types that in general may behave a little bit less aggressively. Now, everyone's cancer is unique and can behave differently. So I don't mean to kind of generalize too much, but in general, that's what we think about. Some of the non-endometrioid types are types that sometimes can have a poorer prognosis. And so we have to be honest about it, but we want to remain hopeful that we have more and more treatments that can treat this. This includes serous carcinoma, which can look very much like ovarian cancer, carcinosarcoma, or clear cell carcinoma. Another non-endometrioid type that is in the larger uterine cancer bucket is leiomyosarcoma, which is a cancer of the tumor of the muscle wall. And that also has very, significant issues related to treatment options and overall prognosis. But again, we're always starting off from a place of feeling hopeful about options that are available for starting treatment. And the earlier a diagnosis is made, that helps us as well. So these are just some common molecular changes. And again, not to put up an alphabet soup, but just to understand that there's like a complexity to not only do we want to know where your cancer started in which organ, but we as GYN oncologists or people in medical oncology who are treating your cancer in radiation oncology may really want to know a lot of these molecular changes, and that can help us as well. So understanding that vocabulary and taking a deep dive in that with your doctor and with your pathology report may help you to kind of know what questions to ask, or ask your doctor to explain this as well. So in general, surgery is the usual treatment for early uterine cancer, cancer that is spread beyond the uterus to the cervix or to other organs, sometimes doesn't get surgery up front or may not even have surgery in the future, depending on how the treatment is going. But in general, the vast majority of women will have a hysterectomy to remove the uterus and the cervix, and a BSO, which is the bilateral salpingo-oophorectomy, to remove the fallopian tubes and ovaries. Other biopsies may be taken, and that includes lymph node biopsies, which I will get into as well. Treatment after surgery, maybe 70 to 80% of people will not need any other further treatment. Treatment is prescribed to decrease the risk of a cancer recurrence, even if all the tumor is removed, and that may include radiation treatment, chemotherapy, or even immunotherapy now. Wanted to mention sentinel lymph nodes because this is a very common way that we are evaluating the lymph node assessment for patients who are undergoing surgery. Oftentimes, I inject not just me, but all of the GYN oncologists who do this, inject dye into the cervix once you're asleep at the time of your uterine cancer surgery. And that dye travels and creates a roadmap for us to tell where we should be thinking about taking a sample of the lymph nodes. Sentinel lymph node mapping allows us to take less lymph nodes to decrease the risk of injury, decrease the risk of swelling in the legs, which can be permanent, called lymphedema. So asking providers, or am I going to have a sentinel lymph node dissection, is an important part of the care and the surgical management of patients. The lymph node information is not found out at the time of surgery, but after surgery, we use that to kind of decide the person's stage as well. So the treatment after surgery depends on the stage. The stage refers to where is the cancer located, and the newest staging system also includes things such as the cell type and some of the molecular types so that we can kind of get a better picture of prognosis to understand recurrence risk, as well as a better picture of what and how to guide treatment options. So the molecular testing and the classification will guide us with that. And it can really vary for individuals. And again, it's designed to either treat any remaining tumor if you have residual tumor left, or it could be designed to decrease the risk of recurrence. So there's always a risk-benefit ratio. Am I going to put myself through this extra treatment? What are the risks and what do I gain? And those conversations are really important to have with your doctor. So when we think about advanced recurrent endometrial cancer treatment, we again think about a personalized approach, molecular testing, hormone receptor testing, cell type testing, and this can include a wide range of treatments. Immunotherapy. So this can be the newer drugs that are looking at chemotherapy. Adding immunotherapy and chemotherapy is a really new advance in endometrial cancer that has more recently been FDA approved. These are drugs that we talked a little bit about the background that gets used for ovarian cancer. A similar chemotherapy background of carboplatin and paclitaxel gets used here, but immunotherapy agents such as pembrolizumab or dostarlimab are immunotherapies that are now FDA approved. So thinking about targeted therapy is also an important element of different types of uterine cancer therapy. We think about a whole first-line therapy as well as the addition of other different types of therapies. And so I don't put this up here, but to know that we really think about a lot of different drugs and how are they better targeted. The targeted therapy group in endometrial cancer is growing daily, so I can't even put all of these drugs on there that have been approved now, but some of the targeting is really important to think about this molecular testing. A category of this would be the Herceptin-based testing or the HER2 testing, which can lead to different types of therapy along the Herceptin pathway. So I'm going to talk a little bit about genetic and molecular testing. So tumor genomic testing utilizes a sample of actual tumor from a biopsy or surgery. And now, usually we would sometimes send it if there was a recurrence, but now we're doing it up front. NGS, next generation sequencing, is the sequencing of the genetics of the tumor. And the DNA is sequenced to better understand mutations. And you may have not a mutation in hereditary, like it's not passed down, but it may be only in your tumor. And how can we use that to better treat you? HRD testing, which is the larger term of homologous recombination deficiency testing, the tumor is tested to see if it has mutations even other than BRCA that can cause cells to lose this specific pathway. And those pathways, if those happen to be lost, patients may benefit from PARP inhibitor therapy as well. So this is kind of an example of how tumor testing can help your physician find tumor treatment options that are more specialized for you. And because there's such a diversity of this, I think just asking your doctor, hey, tell me a little bit about tumor genomic testing and what have you tested for my tumor may be helpful to start the conversation. So cancer genetic testing for hereditary contesting versus, which is called germline testing, so individual genes. I apologize, I may edit this slide a little bit for the future in terms of that, but individual genes versus tumor genomic testing is really important to kind of think about. And so sometimes people will hear about different testing platforms such as Foundation One, Tempest, Caris. I don't want to mention too many names, but or your university or your hospital may have its own testing. So really importantly, all ovarian cancer patients, and that includes fallopian tube and primary peritoneal cancer, should undergo genetic testing and counseling to determine if there's a hereditary breast or ovarian cancer syndrome or genetic predisposition syndrome. We want to be able to share information to allow cascade testing to allow early detection and prevention. And the genetic testing, as mentioned, may guide the primary treatment decision, such as the PARP inhibitor usage. So in general, when we think about genetic, only about 18 to 20% of ovarian cancer will be related to something genetic, and the majority of these will be the BRCA or BRCA1 and 2 genes. But other genes are important, Lynch syndrome genes and other genes that I won't touch on, but really understanding the complexity and that now we test for a panel of genes, not just BRCA1 or 2. So in general, the BRCA1 or 2 genes are generally encode for proteins that help us repair our DNA so that cells do not become mutated and do not develop into cancer. You can inherit a mutation of one copy, and that can basically, over time, if you don't have both copies and you lose another copy, the cells are unable to repair their DNA, and they can actually get this very specific type of deficiency, which predisposes them to getting these cancers. And so this is talking about BRCA, which is more related to ovarian cancer, but bringing uterine cancer back in, we know that there's cancer genetics related to uterine cancer as well. Patients who have a first-degree relative do have a slightly higher risk of developing endometrial cancer, which maybe is around 3 to 5% compared to the lifetime risk. Lynch syndrome, which was also previously known as hereditary non-polyposis colorectal cancer, actually has a very high risk of endometrial and colon cancer. This is an autosomally dominant, so this can be passed on. And in unselected patients where you don't know their family history, about 2 to 3% of women will have this. This is due to what's called a germline mutation in a set of genes that are called mismatch repair genes. Again, you see the theme. Mutations in genes that are actually helping us repair our cells can then lead to more cancer developing if these genes aren't functioning to create the right proteins to be able to do this. So this is really important to kind of think about these MMR genes. And sometimes we'll often talk about, are somebody's tumor MMR deficient or MMR proficient? So this terminology that we learned from genetics is now something that we look at the individual tumor about and can tell you something about both the tumor genetics and if you need to get genetic testing to see if it runs in families. So when we look at like the cancer risk for people who have Lynch syndrome, we see that depending on which mismatch repair gene this is, endometrial cancer, people who have Lynch syndrome have a 20 to 60% risk of having endometrial cancer, depending on which type it is. They have a risk of ovarian cancer, and you can see the risks of colon cancer, which is what this Lynch syndrome is more usually known for. It's important to understand that this can really affect the risk of gynecologic cancers as well. So Lynch syndrome in general for endometrial cancer happens at a younger age. So family history is sometimes how we diagnose it, or we diagnose it by testing the tumor itself, and then people get blood tests or cheek swab tests through genetic counselors. I'm going to shift gears now and talk about cervical and vulvar vaginal cancers. Cervical cancer is less common, which we're very excited about because of the advent many, many years ago of pap smears and HPV testing. We only see about 14,000 cases new in the United States, but in my opinion, this is the most preventable. So any diagnosis of cervical cancer, we really want to say this shouldn't be happening, or it should be happening at a much lower rate, because unlike ovarian and endometrial cancer, we can screen for cervical cancer and we have prevention methods. The overall survival is seen here and varies very widely based on the stage of the cancer, so early diagnosis is a major goal. So the incidence of vulvar cancer, which is cancer that occurs on the outside, I'm going to jump forward for a second, the outside skin of the genital area, and this is a diagram that really shows the vulvar anatomy. There's the vaginal opening, the urethra where the urine is released, the clitoris. The anal canal is down here, but you see the skin and the labia, which are often considered sort of the lips of the vaginal area, are all areas that can be at risk for a type of skin cancer that happens localized here. Obviously, it's not related to sun exposure, but can be related to either HPV or chronic irritation. Vulvar and cervix cancer often gets lumped together because it is sort of in the same, anatomic area and similar risk factors and treatment choices. So again, the incidence is rising of vulvar cancer and the death rate is rising. There are generally two populations. In younger women who get vulvar cancer, it's often related to HPV. In older women who get vulvar cancer, it's often related to other precancerous conditions such as lichen sclerosis, vulvar dysplasia, or chronic irritation that can lead to an inflammatory change and then develop to cancer. So the common signs and symptoms of vulvar cancer, and I really like this one, it's called vulval cancer in the United Kingdom, is itching, persistent changes in the skin, patches of skin that can be red, dark, or white, bleeding from the area that you don't know where it's coming from, burning on the skin when you're urinating, pain or a sore or a lump, a mole that's dark and changes because people can get melanoma or a dark spot on the vulva itself. Treatment of vulvar cancer generally involves surgery as long as it doesn't interfere with the function of the clitoris or the urethra or the anal canal. If it's more localized, we can often do surgery to remove the cancer and to test the lymph nodes in the area. And if it's more advanced, we talk about chemotherapy and radiation, which we'll talk a little bit about as well. So some fast facts about cervical cancer. Cervix is the opening or the womb. Anyone with the cervix is a risk. The majority are caused by HPV, human papillomavirus. It's the second most common cancer death in women and most commonly diagnosed in the 30s and 40s. You're most at risk if you've not really had a pap smear. And again, it can be prevented with HPV vaccine and detection and treatment of early precancer. So the problem is screening saves lives, but there's a lot of Swiss cheese missed opportunities. People who don't get screened are people who just feel like it's not relevant to them. So I see people of all walks of life, all professions, all insurance status who just don't get their pap smears done. They get a screening, but not follow-up. Women who are uninsured, people living in rural area, disabled patients, immigrant patients who may not be attached to a healthcare system, and immunocompromised patients who maybe have immunosuppression due to HIV or transplant or other autoimmune diseases. So these missed opportunities are the problem. This is a very old statistic, but I think it's actually still very valid. So in 2012, and that's not even including all the problems related to COVID and lack of screening during that time period, there were 8 million women that were not screened in the last 5 years. 7 out of 10 women of those women actually had insurance, had a doctor, but they didn't get screened. So that's the problem with our health system, our doctors, as well as us who are not going. Now, HPV can lead to cervical cancer because normal cells can be infected with HPV infection, and most do not turn into cancer, and some precancers can still go back to normal. But if they're not caught here and treated, then cervical cancer can develop. We know that there's vaccination HPV opportunities and screening opportunities that can help us with this. So again, no one should die of cervical cancer. We know that we should do better. Rates are now increasing, especially in higher stages of cancer and especially in lower income counties. And this is really important to think about. We know that HPV can be prevented by preventing infection with the virus, which reduces the risks of getting cervical cancer and other cancers, anal cancer, vulvar cancer, oral neck cancer, and that's for men and women. And we know that precancer cells can be found by and removed. So the risk factors are anybody who has a long-standing infection with HPV that causes cervical cancer. If you're younger age at starting sexual intercourse, you may be more vulnerable because your cervix is not as well developed. Increasing number of partners or having a partner who had multiple other partners. Smoking is a very big risk factor for cervical cancer because it affects how your body's immune system can actually fight off HPV at the local level, and other causes of weakened immune system like mentioned before. But again, coming back to not having a pap test or not getting the HPV vaccine. We know that early detection improves cure and survival because we can treat this in a better way. When you look at distant disease here, that is disease that's spread out of the cervix and away from kind of the local regional environment, we see that the 5-year survival is not good, right? But localized early disease, our 5-year survival may be very high, and we can really treat and cure this disease. Early cancers that are small can be treated with surgery alone sometimes. And very small cancers can still have some fertility sparing options. So talking to your doctor about the size of your tumor and what your options may be will be very important. Of note, some early cancers that are treated with surgery will still need treatment after surgery if there's things that are found at the time of surgery that were unexpected, such as cancer hiding in the lymph nodes or cancer outside of the cervix. In patients who have a more locally advanced cancer, where the cancer has grown perhaps outside of the cervix, grown into the vagina, grown closer to the other organs nearby to the pelvis, we use chemotherapy combined with radiation. This is used for the more advanced cancers, and we can still cure those cancers, but it does have more long-term side effects. I will say just briefly, when we think about the primary treatment for cervical cancer, which involves chemotherapy and radiation, this is a little bit different. The radiation is composed of two components, an external radiation, which is called external beam pelvic radiation, which is delivered in an outpatient setting over generally between 4 or 5 weeks, every day, Monday through Friday. During that time interval, people get chemotherapy, low dose, once a week to make the radiation work better. And the real important element is that there's something called brachytherapy or internal radiation that is a component of radiation that cannot be skipped, because without it, we do not cure the cancers in the best way or cure the cancers in the highest rate. So the brachytherapy, which is the internal radiation, is the delivery of kind of localized radiation more directly into the cervix and the surrounding tissues, and it's done by specialized radiation oncologists. And that's really important to know that those elements of care need to be coordinated and to be done in a timely way. So if chemoradiation is something that you or your loved one has heard about or needs to share, really asking the doctors to share what is the schedule, what are the things that I'm going to need to do to make sure that the treatment is optimal. There are a lot of disparities in cervical cancer. So if you look US wide, the darker blue states are the states that have the highest rates of new cervical cancers being diagnosed. So there's differences by race, ethnicity, immigration status, poverty, or insurance status. Hispanic women are having increasing rates of diagnosis. Black women have higher rates of deaths due to cancer. The Southern and the non-Medicaid expansion states also have higher rates, which reflect poverty as well as insurance and access to being able to get screening. And there's a trend of increasing deaths and incidents in white women in specific states and in poorer counties. So all these things are sort of like an advocacy point that are really important for us as a GYN cancer community as a whole. So it's really important to understand the pelvic exam and that a pelvic and a PAP are not the same. So a pelvic exam is usually annual. A PAP can be more or less frequent now, but a pelvic exam has two parts: the speculum, which is the placement of the instrument, and the bimanual exam, where your doctor is putting in one or two fingers to feel the vagina, feel the uterus, see if they can feel the tubes and the ovaries. And you can test separately for sexually transmitted infections or for a PAP, as you can see this brush here. So again, pelvic exam doesn't mean that you were screened for pap smear or HPV. And very importantly, a pelvic or pap smear does not screen for ovarian or endometrial or uterine cancer. So most women will have a normal pap smear the year prior and still can develop uterine or ovarian cancer. Now, there are clinical trials looking at like, hey, what else could the cells tell us? And that will be hopefully very exciting in the future. So we screen by checking the cells of the cervix and checking for HPV. We generally start at age 21 until age 65, but please note that cervical cancer can happen in women over 65, and about 20% of our cases happen in older women who just have not gotten a pap smear for many years. So if you're in your 50s or 60s, or if you know anyone in your 50s or 60s, that's the time to say, am I up to date? Can I just get one last pap smear so I know my HPV is negative and then I can exit screening, right? But you still need a gynecologic exam to make sure that you're testing for vulvar, vaginal symptoms, cervical symptoms, any other ovarian and endometrial symptoms. So again, we talked a little bit about this, about when to test. So I won't belabor this, but again, starting at age 21, and I think as I'm thinking about this, one of my slides goes a little bit lower, but again, stopping at age 65 if you have been up to date with your screening thus far. If a PAP is abnormal, you do not automatically have cancer, but you will be asked to have a procedure called a colposcopy that can be done in the office to just get a magnified view of the cervix and possibly take some biopsies and samples that may help us decide if we have further need for any other treatment or any other surgery to remove a precancer or to treat an early cancer. Coming soon, which is most recently FDA approved, is the idea of HPV self-sampling to improve screening for cervical cancer and to really think about how we eliminate cervical cancer as a public health problem in the future. So symptoms of cervical cancer can include early irregular bleeding, bleeding after sex, pain, irregular vaginal discharge. Rare symptoms can include bowel or bladder functions, back pain, leg swelling, but early cancer often has no symptoms, and that's why we want to catch it with screening. But if these symptoms are happening, making sure you're advocating for getting a pap smear and a good pelvic exam. Some of the next slides I'll go over a little bit briefly, but we've talked a little bit about disparities again, so I'm not going to go over and spend a lot of time on these, but there's a lot of really good information for those who are interested. HPV, to even back up a little bit so you can really understand cervical cancer, stands for human papillomavirus. There's more than 200 types of human papillomavirus. It can be harmless and can go away by itself, but high-risk types can lead to the infection of the cervix and then eventually lead to cervical cancer. Again, we really want to catch people here, and an HPV-infected cervix can be caught by pap smear, and we want to avoid progression. So people who smoke are more likely to progress. People who are immunocompromised may be more likely to progress. But we want to kind of try to find early detection so we don't have to do more radical treatment or surgery. So again, it's really a problem. 80% of all of us will have an HPV infection. Over 14 million people, including teens, are infected every year. And that's why HPV vaccine is such an important element of gynecological cancer prevention, because it can prevent vulvar, vaginal, and cervical cancer. This kind of tells you it also prevents things such as dysplasia, precancer, genital warts, and other bothersome abnormalities. So I think the really important part about it is that because it's so common, that's why our push is for HPV prevention in terms of the ability for us to prevent it via education as well as vaccination. It's transmitted via skin-to-skin contact, so that's even before sexual intercourse. It is considered a sexually transmitted disease, but I have mixed feelings about this because I don't want to increase any stigma related to cervical or any of the other cancers. You can see here how the normal cells should look under the microscope, and as HPV starts to change the cells, this is how we as physicians, or really our pathologists, can actually look at the samples of pap smears or biopsies to tell us what to do in terms of guiding treatment options. Most abnormal paps will not be cancer but need follow-up. This is again the colposcopy element, and again, when we should have screening done. So it's not just screening. The screening is not the only thing. That's why we're thinking about prevention, because there's no available screening for vulvar vaginal cancers in the GYN world. And there's no availability for the oropharyngeal cancers, which are increasing even higher in men as we go forward. Here's kind of an outline, old outline of different cancers related to HPV. And you can see in men, the oropharynx cancers are really rising, and there's no good screening test for that. Talked a little bit about this, about where those cancers can be. And this is actually, the vaccine prevents this as well. And the guidelines are starting at age 9 to 14, 2 doses, and higher than that, age 15 to 26, as well as thinking about the vaccine is now available for the last many, many years up until age 45. So now the current indications include vaccination for prevention of all of these different cancers, age 9 to 45 as well. And 27 to 45, thinking about who could potentially be recommended to have this. And I think it's important to think about that adults are still at new risk, and life circumstances can change. And it's not recommended during pregnancy, but immunocompromised patients should get this as well. So back in here, we know that there's disparities in terms of who gets the vaccines. And so that's important to kind of make sure that we keep this uptake going. We're not vaccinating enough children. The vaccine fears and concerns are valid. Worry about early sex are not true. The vaccine cost is covered for children. And I think it's really important that we make sure our providers that we're asking for this. So for cervical cancer, we really think getting screened, getting the HPV vaccine, recommending it for your children and your grandchildren, getting boys and girls vaccinated, and promoting awareness as a whole. I'm going to shift very briefly to just talk about a few things related to just supportive staff and services under GYN Cancer 101. So who should you know? Knowing your chemotherapy nurses, your physician assistants and nurse practitioners, in addition to your doctor, the fellows, the social worker services that may be available, other community resources such as the OCRA resources, the Women to Women program. There may be other community cancer resources. GYN oncologists are often involved with the Society for GYN Oncology and the Foundation for Women's Cancer, as well as cancer nutrition is an important element. We really want to make sure that you're taking the time to address the survivorship issues that can come up during any time of your cancer diagnosis, which includes psychosocial concerns, fertility concerns and consequences, menopause, which may be early or sudden, other illnesses that you may be managing, issues of sexual function, issues of fatigue and physical functioning after surgery and chemo, and lifestyle after cancer diagnosis, which includes prevention and improvements in quality of life related to diet and exercise recommendations. Potential chemotherapy side effects. Everyone is unique and not all patients experience these issues, but really making sure that you talk to your doctors about specific side effects. These are ones that are more chemotherapy related potentially, but not immunotherapy related. So really getting an understand of like, how do you manage your side effects and who's going to help you manage those proactively. I think there's the use of complementary and alternative medications to address both physical and psychosocial needs and symptoms. There's yoga, mindfulness, meditation, acupuncture, massage therapy. Alternative medication should be discussed with your doctor during and after treatment to make sure that there's no interference. So before you take any supplements or anything like that, talk to your doctor, talk to your pharmacist, because those can interact in ways that we can't always predict. We know the goals and limitations of during treatment and after treatment, but we know that mild to moderate activity during chemotherapy can benefit you both physically and emotionally, but knowing your limits, don't be discouraged, small steps. Understanding your resources locally, again, ask for a physical therapy consult, ask for a nutrition consult. We often work very closely with our medical oncology specialists, some of whom are specialists in GYN cancers, as well as a care team model. We don't have enough GYN oncologists to reach into all the counties we know, but many GYN oncologists will provide both surgery and chemotherapy guidance and therapy, while many will work closely with our medical oncology cancer colleagues in either cancer centers or community practice. So thinking about, is distance to treatment site an issue, your comfort level, how do you partner with Gyn-Onc and Med-Onc, and think about your links to kind of things such as clinical trials. Finally, I would say thinking about like, how do you advocate for awareness about GYN cancers for yourself, one-on-one discussions, sharing this information with trusted friends and family in person, creating a community forum, social media, careful with your sources, no fake news. So really good sources like OCRA, and getting involved with localized groups. This is an example of a cervical cancer patient who decided in our state of Illinois to proclaim back in 2016 Cervical Cancer Awareness Month. And this was kind of a small effort that she did locally. She was a big crocheter, and she put in just like information about cervix cancer in the most random places. But I think it's important to kind of think about like, how do you take your role and advocate about this type of education and awareness? And we really appreciate that from as a GYN oncologist and as an advocate. So anyone can be an advocate, cancer survivors, healthcare providers, and caregivers, and we all offer sort of a unique perspective. So I hope that you can kind of share some of the things that you've learned today at this session, and reach out to any of us if you want to be more involved. Thank you so much.